Hey, you awesome folks! Thanks for taking this journey of discovery with your guide, Keith Haney. You're listening to the Becoming Bridge Builders podcast, your favorite podcast for everything from racial reconciliation to education innovation, justice reform, and leading change in the 21st century. This podcast is for people who love to be challenged with difficult topics, but want practical solutions to solve these challenging issues. Becoming Bridge Builders makes change possible. Each week on the podcast, Keith invites innovative thought leaders to share how they are building bridges in their area of expertise. You will hear breakthrough ideas and concepts that are changing the world. He's featuring guests who are best-selling authors, leaders at Microsoft, entrepreneurs, leading educators, professors, lawyers, and so many more. Listen in to learn how you can be the bridge to the change you are seeking.
I'm great. How are you? And it's an honor to be invited. Thank you so much. The best piece of advice I received was from my mom. And I remember her saying, you always need to know who you are. There will be changes in life and as you continue to grow, but to know your strengths and weaknesses are key to continued growth. And interestingly, she passed in 2019, and I went to the hospital to see her, and I wanted to know her cognitive functions. And I said, "Mom, do you know who I am?" And my mom was 92 then, and she looked at me as if to say, "Are you kidding me?" The look on her face. She said, "I'm getting ready to meet my maker and my husband, and you don't know who you are." But she grabbed my hand really tight, and she said, "My dear, seek and you shall find." That's who my mom was, and still is to me. You know, yeah. Oh my goodness, it's just it's at her 90th birthday. The whole family got together and everybody was singing happy birthday to Aunt Joyce, cousin Joyce, grandma, mom. She said, stop it, too many words, too many words. I'll sing to myself, happy birthday to me." So that's who my mom is. That's my and she's always had so much insights, and I really appreciate it to say, as you grow and times change and things change, realize that your strengths and weaknesses may also change as well, and to recognize and be who you are. Yeah, yeah, that, yeah, yeah. I think I would say my family, my entire family, and it was a learning curve. My family originally came from Jamaica, and so my dad came first, and then my mom came like 4 or 5 years later, and we stayed in Jamaica with my grandmother until it was time for us to come to the United States, and that whole transition from coming from a majority culture where you were just seen as Jamaican. Nobody said you were a black Jamaican or Chinese Jamaican or Indian Jamaican. You were just Jamaican. When you came to the U.S. and you realize that you come to a minority culture, some of us had more preparation than others. And that was a learning curve for my whole entire family. How do we transition from a majority culture when you never use the word that I'm black? you know, because everybody was black. Not everybody, but the bulk of the population. And then you come to a minority culture, and as I said, some of us had more preparation than others, and so we had to combine and understand some of um, the unforeseen circumstances that we had to endure and live in. And so the family, I think, supported us all, including when my grandmother came. Oh, my grandmother was a piece of work. Yeah, you know. So, and I also think when I came, the other part of the influence and was by the time I came here around 10 or so. I'm not going to tell you my age. And after a while, I went on to, high school and junior high, high school, and then to college. And at that time, it was the beginning and the start of the whole Black Power movement. And everybody wore afros, and everybody would say it loud, I'm black and I'm proud, you know. And so at Boston University, I was one of four. We are still friends to today. There were six black students, and we were friends. The four of us were friends until today, and we supported each other in the whole quest to become physicians. And it's just been an amazing experience, and they have been, I would say, also instrumental in who I am today, and also I would say the training that I went to medical school, the University of Buffalo School of Medicine, and then I went to train at Harlem Hospital. And back then we were Afro wearing black residents and Vietnam protesting long haired white residents. And we came together to Harlem not because we had to, but because we wanted to. And the environment there under the leadership of then, it was called then the director of medicine, not the chief medical officer, Dr. Thompson. And it was embedded in our brains, you know, provide excellent care. And he didn't care whether the person was a churchgoer or addicted to narcotics. Excellence care was the mandate. And it speaks to who we are because years later, in 2017, all of us came from across the country, north, south, east, and west, to honor Dr. Thompson. And so when you have 200 people come, you know, it tells you who the and taking care of Harlem is was predominantly black population, obviously, and now today they talk about social determinants of health as a reason why health outcomes is problematic. Back then in Harlem, the idea was because you live in the projects doesn't mean your blood pressure can be controlled. Simple, and that's where. So the combination of you know my mom, my family migrating from Jamaica to the U.S. and learning the culture, and then going to college and meeting four other students that were pre med and learn and then training at Harlem Hospital has really defined who I am today as a not only a physician but also as a human being because we were not allowed. It was embedded in our brain. Get the patient well by morning report by the chief residents, and the fact that I knew what I learned at that point, Keith, is that black students came from all over the country, and I realized that there are similarities in what the experience is for the black population, but then there are unique differences. So I'll just give you an example. We were sitting at the lunch, for lunch, and one of the residents, he was from the backwoods of Arkansas, and his parents and family were essentially sharecroppers or farmers, and they raised $100 for him to go to Harvard, and $100 back then was a lot of money. And so he went to Harvard and then chose to come to Harlem Hospital. And most people don't know Harlem Hospital is what who saved Dr. Martin Luther King's life when he was stabbed. And so he was had the envelope and he was sort of you could see the proud. He was so proud. And we said, "Oh, what's going on?" We thought maybe he was going to be transferred to another hospital. And he said, my father was the first black mailman in Arkansas. So most of us around the table were from the tri-state area, New York, New Jersey, and Connecticut. And so we said, and I remember somebody said, "Oh, you mean the head of the post office?" Because everybody in New York who delivered mail were black. So when he said his father was the first in Arkansas, so we said, that can't be. You mean the head of the post office? And that's when I start to realize, even though circumstances are the same, there are unique differences based on where, where the geographic location that person is from. And that was a learning curve, you know, at that point for us who were in the tri-state area, you know. Yes, and it's I was touched by the host of becoming the bridge builders because back in 2008 or so, I developed the first care management program in New York City Health and Hospital at Queens Health Network, and within the contents of the care management program was the bridge team. And the whole idea of the bridge team was to bridge the gap. Whatever the gap is, that's the role of the bridge team. And so, and I'm honored to say that it's still operational till today, you know, and it was made up of care managers and case managers, social workers. That's what I had on my bridge team. And the bridge team in Elmhurst, the population was a large Asian Indian population, a large Hispanic population, and a growing Russian population. And the black population was small compared to everyone else. But in Queens Hospital, the largest population was black, and the second population was Indians from Guyana. And I'll tell you how I came to this concept of in the lookalike syndrome. you know, the bridge team, and the whole idea was bridge the gap and focus on the most vulnerable. And in Queens, the most vulnerable population was patients with sickle cell disease. And this is the beginning of why I chose to write the book, is what I call these stop in my tracks moments that led to simple boots on the ground solutions. And why do I say that? So these when you design a system or a process and you implement it and you think you're really on target to meet your goals, and then what I describe as the stop in my tracks moments. So we went in, she was 18, and we went in to see her, and everybody was complaining. She's so disrespectful, attitudinal. She's always in the emergency room, drug seeking and the whole nine. And attitudinal. And I'm thinking, what 18-year-old without a life-threatening disease is not attitudinal at some point? Let's give her the benefit of the doubt. So we're about to enter the room, and these stop in the tracks moments always seem to happen at Monday morning, 9 o'clock. you know, I don't know why. So they were about to enter her room, and she said she had this thing. I'm on my phone, and the team is whispering. That's what we're talking about. I said, just relax. So she got off the phone, and I was about now. The team said, okay, let's enter her room. And I'll never forget her statement. She said, if you have a cure, come in. If you don't, and she pointed, keep walking. I said, wow. Was I expecting that? And I literally remember putting my foot back on the ground. And then I became the child and she became the adult. And why do I say that? She said, "Did you hear what I said? I'm going to repeat myself one more time." Isn't that what we tell our children when they're not following directions? So she said, "If you have a cure, come in. If you don't, keep walking." And I said, "I don't have a cure, but let me think about what you said and I'll come back and see you later." I went back to see her 5 o'clock. Who she was and who we perceived her to be was not who this individual. She was highly intellectual, highly caring, and this is her story um, and she was the first stop in my tracks moment. And at 16, her mom got off the bus, developed chest pain, got taken to a hospital, and died of a heart attack. At 17, her sister got admitted to a hospital for sickle cell crisis and died of sepsis. She's now 18. She lives with her uncle, and from the way she described him, is more a food, clothing, and shelter type of guy. He's not a touchy-feely type of guy. And she said another powerful statement. "You doctors don't teach me about sickle cell. Sickle cell teaches me." And we literally hugged, and it was tearful, and 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 you know, I decided, we have to do something about it. I said, "Oh, have you ever been referred for counseling?" She said, "No." "Have you ever had depression screen?" And she said, "No." So I went to the emergency room and said, "We got to fix this. We have to create a better environment." So long story short, when the bridge team, so I had care managers in the emergency room. So if a patient with sickle cell came in, we would ask that patient if they wanted to join a sickle cell support group. So I created the first sickle cell support group, and it was uncensored. We had a therapist on the team as well as care case managers and social workers. And once that was done, and this is where you heard the stories, because this particular group of patients, their stories are not told. They're treated and being dismissive and being referred to as drug seeker, which is not supported by medical literature. They're the least addicted but the most vilified when it comes to people who require pain management. And Keith, when you heard the stories, and I keep hearing the story that I, the word hate, and I said, "Oh my God!" And I said, and they could speak, and I had it before. We provided lunch, and it was right an hour before hematology clinic. And one patient said, I hate my mother." I said, "Oh my God, why would somebody hate their mom?" She said, "Oh, I don't hate her now. I know she loves me over the moon and she wants the best for me, but I never understood when I was younger. Why did she keep me in so much pain? Why did she side with the doctors to keep me in so much pain? Why didn't they just let me die?" And then one of the other story about hate, she said, "My brother hates me." "Why does your brother hate me?" "Because I suck up all the oxygen in the room." She had sickle cell and he does not. And that's when I realized there's no family counseling that's offered to this population. And so I said, "Give me an example." And she said her brother was on the basketball team. The team never went anywhere. All of a sudden now they made it to the semifinals. So the finals, if the semifinals is today, the finals is tomorrow. And at 1 a.m. in the morning, she developed sickle cell crisis, and the mom and dad had to take her to the basketball game. I mean, to the hospital, and he had to go to the game by himself. You know, and when I do these presentation and I mention that, somebody said, "Well, why didn't the dad take her to the hospital and the mom go with her to the basketball game, or one of the pair?" I said, "She is in crisis, and the person that's driving her can't look at see the traffic, and their child is in pain, could actually have an accident, so both have to take her." And that's when I realized for this population, there is no family counseling. And so we started the sickle cell support group, and we were able to get so much information and caring. And in addition to that, I created a transition of care from adolescents to adults, you know. And yeah, Yeah, well, it's an international disease. It's not just black people. People in Europe have it, people in the Middle East, people in India. Matter of fact, one of a conference I was on, this white male daughter had sickle cell. He's from Georgia, and everybody said they couldn't have sickle cell, so they sent the test to three different labs, and it came back positive. And he is from Greek ancestry, you know, and he said his daughter doesn't get treated that way the same as other um, patients with sickle cell. What happens is, it's really has to do with the slave trade, where it was a protective gene to protect against malaria in Africa, and once people came from with the slave trade, there was no longer that protection, and sickle cell testing was positive, and it if you had the SS disease versus the trait. And what happens is, when you're in crisis, the blood cells sickle, they change the shape, and it prevents blood and oxygen from flowing to other organs. And that's why a lot of the patients with in crisis, the pain, because there is no circulation, blood circulation or oxygen to these organs, and they could end up with having strokes. They have kidney problems. They get infection, and it's just unconscionable the way they are treated, and it's no justification. And there's an article from Dr. Zemsky. He's a pain specialist in Connecticut. He said difficult patients are not just born. Sometimes they're created through the medical system. Not only the system failed to cure, it may have done unpleasant things to make matters worse. And patients come back to the emergency room not because they are drug seeking, is proven. They were undertreated the first go round. And so one of my passions is about improving the treatment of patients with sickle cell disease. But before you get to the treatment, you have to value me. And so I've developed a tool, actually, and I could share it with you, a patient complaint tool. Yeah, as to how they were treated. And we're looking to see if we could have a collaboration with various community-based sickle cell organizations, because this tool, if somebody complains, that when I speak to patients, when I speak, I'm on the board of for sickle cell Westchester Sickle Cell Outreach, and when the patients speak and they said, "Did you complain?" I say, "Yes, I gave a complaint," and I send it to the CEO. Then they have the patient see patient advocate, but then it goes nowhere. So the tool that I developed, it's going to go to this ED director, the chief medical officer, the CEO of the hospital, and the board of directors. And so everybody can say, well, I didn't know anything about this problem. Well, now everybody will know. And that statement that I wrote, that I quoted from Dr. Zemke, it's on the bottom of the form. And one of the questions is, does this, did this statement apply to you? Did people do unnecessary things to make matters worse? Yes, no, or if you're not sure. And if yes, please state why. So it's just new. It's just a hot off the press tool, and I just copyrighted it. And we're looking now to have a meeting to see if community organizations would be able to, if we implement it and do a research. So we're having a meeting with a research and an epidemiologist who has sickle cell as well. So, we're going to have the first discussion at the beginning of next month. Yeah. I think the first thing we have to recognize is the lack of human value. And everybody now, there's nicer words. We went from health disparity to health equity, non-compliant to non-adherent, and but there's no solutions. And what I realize is, from my conversations with about 1,000 patients over the course of time, from all ethnicities and nationalities and race and gender and socioeconomic status, and I realize that people have to recognize the term when everybody say treats you have to treat the patient with dignity and respect. Yes, that's true. But if you don't value me, is dignity and respect going to come into your mind? you know. So some of the solutions is to what I do. I look at it from a perception reality. What is the perception and what is the reality? And I've done a lot of surveys, both patients and staff. And the age gap scores. Everybody says, what does the patient think about the care they receive? Would they recommend the hospital? But there's no survey. What does the staff think about the population they serve? And you could see how that could actually affect the age gap score. And so I did a lot of surveys, and the same question I asked the patient is the same question I asked the staff. I give an example: heart failure. I was in charge of the congestive heart failure readmission prevention program in I think 2014 or 15, when Medicare said if you come back in 30 days, we'll only pay for one admission. But prior to that, they would pay for two, four, six, eight. So the average heart failure patient is taking about 5 to 6 medications 3 times a day including medications for comorbid conditions. And so I asked the staff in the emergency room and inpatient, why don't patients take their medication? And the top answer was cost. And one of the doctors said, what do you want me to do about it? I can't call the social work. But what if I told you, Keith, when I asked the patients who are in the bed, not one mentioned cost? Guess what the answer was? We don't take our medication because we think we're taking too many medications. Exactly, exactly. So if you're going to design the system based on the perception that cost is the problem and not realizing the concerns of the actual people who are actually taking the medication. And just a side note, I was talking to a friend of mine whose daughter-in-law just had triplets, and she said, Aunt Marva, that's like somebody telling me how to take care of triplets and never had a baby. And I say this to say, if the perception and the reality is not the same, if your perception of me is not the reality, my health is going to go south. But if the perception and the reality is the same, good, bad, happy, or sad, we have an opportunity to collaborate. And the first thing I said, let's adopt the concept of the common thread, the human experience. What do I mean by that? Once accurately diagnosed, there is no human being on planet Earth to give it back. It's irrespective of race, gender, ethnicity, socioeconomic status, language spoken, where you're from. Once accurately diagnosed, no one can give it back. The millionaire can't say, "Oh, I'll give you $1 million to take the cancer back." Oh, that's not enough. I'll give you 5 million. In life, we have choices. You don't like the schools your kids go, you could change. You don't like your job, you could leave. You don't like your family, you could move to another state or whatever. But once accurately diagnosed, and maybe health system can adopt that in a more empathetic and less judgmental manner, and to recognize that the bulk of us taking care of patients never laid in a hospital bed. And those that do are women delivering life and patients, in some cases, trying to prevent death. And that's one of the simple solutions: adopt the common thread. The second one is the negativity in the medical records. And so, what do I mean by that? We talked about it a bit. Non-compliant. How many times have you heard that word? Yeah. And now non-adherent. But how many times have you heard the why question? So exactly. So like I said, in medicine, we're trying to do no harm. And what's interesting is that the why question is embedded in our brain. Why the fever? Why the headache? Why the abdominal pain? Why? But when it comes to asking a patient, why didn't you follow direction? There's no why. And if you write non-compliant in the medical records 2 or 3 times, that patient is under the help us. Nobody cares about that. And it's been proven that negativity in the medical records is more geared towards the black population, and particularly black males. And I'll just give you one of the stories in my book. That's the why question. And it's just, I'm so passionate about that, this because it's a simple solution. 60-year-old African American male recently diagnosed with congestive heart failure, returns 2 weeks later, heart failure, decompensated due to non-compliance. And one of the nurse, when that person goes to the unit, do you think anybody's going to care about that person? And one of the nurses, who is not a part of my team, said, so he just got diagnosed with a life-threatening condition and he doesn't take his medication. I got other things to do. So my team had to ask, why don't you take your medicine? I can't take the water pill. And the water pill is a diuretic that's used to flush excess fluid out of the body so that the heart can pump better. So there's a lot of patients urinate a lot when they take the water pill. And next, why can't you take the water pill? And I'm glad you're sitting down. He said, because I drive the number 7 train. So if you're if train driver and you take the water pill, you can't say the train is delayed because the driver has to find a bathroom. I mean, yeah. So the same cardiologist that was ignoring him, I brought him in. I said, when is your shift? 11 p.m. to 11 a.m. What do you do when you get home? I do my chores. I do some chores. I make breakfast. I take some of my medications. I take a nap. But if I'm going on my shift, I don't take the water pill. So the same cardiologist who was ignoring him, and that's what I realized. People, we could change mindset. He said, okay, when you get home, take the water pill. Be aware that it may wake you up during the day, but by the time you get to your shift, you'd have less of a reason to urinate. But to the degree that you do, we're going to give you a cubicle to use in the private space. And you know what the patient said? If I knew I had to choose between peeing and breathing, I would have chosen breathing. But expand the conversation now. You know, that patient, without the why question, that patient would have been readmitted multiple times. And if by chance he were to pass at mortality, it would have said died due to noncompliance. And it's a learning what we learn. We don't want to have patients choose between their health and their jobs. And we were able to, and he did well. And the other why question, what we don't hear when you have the negative non-compliant, nobody mentions patient fears. If I'm fearful of something, you could see why. And I have examples. Uh, um, you know, patient kidneys were worsening, and he refused dialysis, refused. And that's all they wrote in the chart, that refused, patient refused. And I said, did anybody talk to his wife? No. Does she come to see him? She comes every evening after work. So I went to see her, and I said, I know you love your husband. You're gonna really have to convince him to take dialysis because he may not be here with you much longer. And then she said, I mean, it blew my mind. The first, she said, I don't think I want to do that. I said, what? you know? And then she said, tell me why. She said another powerful statement. I don't think I could live with myself. I said, tell me why. Because our neighbor down the hall from us went on dialysis and 2 weeks later he died. So could you imagine the guilt and the trauma if that happened to her husband, knowing that history? So I brought in the nephrologist and I explained to him, and he said, and he explained, I don't know why your neighbor died. Maybe he had a stroke, maybe he had a heart attack, maybe his kidneys were. But one thing I will tell you, if you agree to dialysis, I will be there with you for the first week. And nephrologists do not go to dialysis. And that's why it was encouraging to realize that changing people's minds, healthcare professional minds, it's not hard to do, but it's to do with conscious and unconscious bias. And then what I realized in speaking to the elderly black population, that they're not included in the cultural competence conversation. Cultural competence, as far as I'm concerned, has to be American born physicians to foreign born patients, but also foreign born physicians to American born patients, and American born physicians to American born patients who are different than themselves. As I mentioned earlier, these stop in my tracks moments always happen Monday morning, 9 o'clock, and it's in Brooklyn. So Brooklyn has a large Caribbean and African American population. I need to know who's Caribbean from a cultural perspective, and is what I refer as the look-alike syndrome. Because we look alike, we have to understand the unique differences, if any. And so I did a presentation and I said, okay, And the reason why this came about, one of these stop in the tracks, we went to see a patient, and I said, Queens, he was from, I mentioned the Guyanese population. And one of the team members said, oh, where in India are you from? And he was upset. I'm not from India. I'm Guyanese. I'm Caribbean. So this is what I call the lookalike syndrome. I said, go tell a British person they're Irish and see how far you get. Go tell a Chinese they're Japanese. Go tell an Indian they're Pakistani. Go tell a Jamaican they're Trinidadian. Go tell a person from Ghana they're Nigerian. And most important, go tell a New Yorker they're from New Jersey and see how far you get. And so we needed to find out because we went into the room and we introduced ourselves, and I said, where good morning, and I said, where are you from? She said South Carolina originally, and my next question was, when did you come to New York? Because I need to know whether you're visiting and you got sick or whether or not you live here because the transition would be different. And you know what her next statement was? Good morning, 9 o'clock. My parents first step away from slavery, and my grandparents were slaves. And I said, wow. I said, tell me about it. And some of them spoke in codes. My family picked cotton on a plantation that was not ours. And then we had to get up at the crack of dawn and pick 300 to 500 pounds of cotton. And then I had to walk 10 miles to a segregated school. And I said, 10 miles? To myself, we can't even go 5 blocks without calling an Uber. So then and her body language changed. I said, how do you walk 10 miles? And she said, well, if you want the tone, well, if you want an education, you had to. Like, what part of this don't you get, stupid? you know? And then she continued her education. I had to look it up. It's a 2-year black college in South Carolina, Voorhees College. And then she came to New York in the 30s and 40s, which was when the migration was. And 95% of the cohort of patients in or residents in New York are from the Carolinas. And I had to go and do the research as to why. And it's after the Emancipation Proclamation when they got their first representation in Congress, their communities started to do better than the white community. They built schools, churches, businesses. The plantation owners' property went south because nobody was picking the cotton. And over the course of time, the Ku Klux Klan came in and burned the place down, and they came up the coastline to New York. And there's a documentary on the Wilmington Massacre. So she came to New York and she continued her education in and became a dietitian. And so, I said, do you mind telling me as how much you made? When did you retire? She's retired. I said, do you mind telling me how much you made? She said $200 a week, but others made more. And what's really key, I don't know if you ever heard of the school Stuyvesant High School, is a very performance. It's a highly performance driven school. It outshadows private and public schools in New York. So when you get into Stuyvesant, you could tell you that you are, gifted, and your academics is A plus. Her two children were two of five black children to integrate Stuyvesant High School. And one became an electrical engineer, one became a mechanical engineer. And talk about I almost screwed up cultural competence. So I said, you're going to need, you know, home care, service. And she said, I don't want anything that's not mine. She thought I was giving her a handout. And I tell my team, when you mess up a conversation, whether you meant it or apologize, apologize because you're not laying in that bed. I said, oh, I'm so sorry. Maybe I didn't explain it the way I should. You know, everyone that has Medicare, and I didn't use the word entitled. I said everyone that has Medicare home care services is is in the Medicare plan. She said everyone. I said yes. She said okay, and that's when I realized. And some of the conversations and the role of religion in the elderly black population is not included. And some of the stories in my book, and and that's why I have a chapter. They're in our hospital beds and not in the history books because and the notion that the elderly black population has the worst health outcomes in all disease categories is a major problem. And we were able to decrease the readmission for heart failure from 30% to 18.7% in just about 2 years. The population didn't change, the clinical care, the so called social determinants of health didn't change. It's not like a whole bunch of rich people came in on the 18.7. What changed was the heightened human value, understand the need for cultural competence, for particularly for the elderly black population. Never use the word non-compliant without asking why, and to listen to what the patient has to say as a contributor to improving the health of the health outcomes. And it was, you know, it was humbling. And just the last example of the role of religion, when the patient said it's in God's hands, you know, and one of the nurses said, well, she wants to blame it on God. No, 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 and she don't want to participate, whatever. So then I said, no, she truly believes it. And I went over to her with the team, my team, and I held her hand. I said, I know God is taking care of you, and I know God loves you. Would it be okay to give us an opportunity to help you with your medical condition, heart failure, because we would like to please God as well? And she said, Sister so and so, amen. And she grabbed our hands and she prayed with us. It was humbling, and so I think my approach to health equity is these simple solutions that came from these stop in my tracks moments that led to simple solutions, and it came from the patients, you know. And what I'm very appreciative of, there's the bridge team is still operational in Elmerson Queens today, and the sickle cell support group is still operational. Hmm. Yeah. Yes. Oh, absolutely. For all patients, particularly black patients, if you go to the doctor, whether it's in ambulatory care, private practice, or in the hospital, and they ask you, did you take your medications or did you follow directions? And you say no, wait a couple of seconds. If they didn't ask why, say, would you like to know the why, the reason why I didn't do it? And then please don't write non-compliant in my medical records without the why question being answered. And in the event that you do that, please be aware that it could affect my health outcomes. I think to me that's where it starts. Because if you don't ask me why, and that's what I would really want patients to be aware of, because a lot of patients are not aware of negativity in their medical records that could contribute to poor health outcomes. And so it's so important to say, do you want to know why? And please do not write non-compliant in my medical records without asking me why, because it could have a negative impact on my health outcomes. And if that would be a major takeaway, because it's simple, it doesn't require a whole lot of paperwork, it doesn't require a whole lot of conversation. Simple, because you're going to be asked, did you follow directions or did you take your medicine? I'm sorry. Oh, my legacy. Oh my goodness. It would be that I had the opportunity to design and help to improve the health of particularly the black population across the board. Because currently there's no hospital, and I've researched it, that say, tell me a hospital that has the best health outcomes for the black population, and there's none. So if my legacy, if that could be a legacy, that would be that there is documented data that the black population has now better health outcomes, and that I was a contributor to that. Yes. So I think the book will be out on Juneteenth. So I could keep you posted as to we're on target for Juneteenth because it's the end of slavery. It's 1865, and it's my birthday. you know. And I'm on LinkedIn, and I could send you the link. I'm on LinkedIn. You know. Yes. 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 Please do. Yeah. Yes. Exactly. And it's a simple solution that no one talks about. Yeah. 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 And you get to know the human being rather than being the perception of who you think that individual is. Because, and the last thing I'm saying is, if my perception is not the reality of who you are, your health could go south. But if the perception and the reality is the same, good, bad, happy, or sad, we have an opportunity to collaborate and not be judgmental. So that's the last thing I'm going to say. Absolutely. And thank you so much, Keith. It was an honor. And the bridge team will follow the bridge builders. Yes. Yeah. Okay. Thank you.
Do you know that most entrepreneurs hit a revenue ceiling and have no idea why? They're working harder, spending more money, running more ads, but revenue stays flat. My friend Dr. Noah St. John calls this the invisible break. He's giving our listeners a free revenue ceiling audit to help you see what's really holding you back. You'll get a free 30-day membership to NoahBot, giving you access to Dr. Noah's 30 years of experience to help you reach your next level. But hurry, because there's only 50 available this month. So if you're tired of being stuck at the same revenue level and want to finally break through, get your free revenue ceiling audit at drnoahvault.com in the affiliate link that'll be listed in the show notes.
Thanks for listening to Becoming Bridge Builder. If you enjoyed this episode and want to help support the podcast, please subscribe and share it with others. Post about it on social media or leave a rating and review. To catch all the latest from me, you can follow me on Instagram at bkeithhaney and on Getter and Twitter at RevHeadpin. Thanks again and tune in next time.